Is it possible to end AIDS as a public health threat by 2030? The United Nations thinks so, and the guests on this podcast series certainly hope so. But it's going to take effort, innovation, connections between people and within communities, and funding, which we are going to explore this season. Welcome to Can We End Epidemics, a podcast series by the global biopharmaceutical company ViiV Healthcare, in association with its biopharma majority shareholder GSK, and developed by Foreign Policy's FP Studios. I'm Henry Bonsu. This episode, I look at the importance of preventing infectious disease and promoting wellness as a critical tool in ending HIV transmission. Is it enough to rely on innovation in health technologies and products, or should we let communities drive home the power of prevention to improve public health? Let's discuss. With us, Shereen El Feki is a sexual health and rights expert and the former regional director for the Middle East and North Africa at UNAIDS. She's also the author of Sex and the Citadel, which digs into the sex lives of men and women in the Arab world. And Randevyn Piérre is the regional director in US External Affairs for ViiV Healthcare. He's based in Atlanta, Georgia. Welcome, Shereen and Randevyn.
Hello, hi, Henry. How are you?
It's good to have you both with us. Shereen, let me start off with you. The basic premise, the opening premise is it possible to end AIDS as a public health threat by 2030? What's your starting position?
Gosh, big start. So this is among the Sustainable Development Goals. I think it's safe to say that we're now at 6 years out to 2030. It's a tall order. Those goals, I would say, are more aspirational than actualizable, and it depends where you are in the world. If we look at, for example, the global AIDS strategy from 2021 to 2026, which is sort of the global blueprint to take us to 2030, the ideal goal is on that path that 95% of people living with HIV know their status, 95% of people living with HIV are on treatment, and then 95% are what we call virally suppressed. Globally, in some countries, we're getting to 95. There are a handful that are there, 16 are on track. Speaking from the Middle East and North Africa, for example, we are very far from that. Only about less than two-thirds of people living with HIV know their status, and less than half are on treatment or virally suppressed. So it depends where you are in the world, but we have a long way to go. And the problem now is that the steps that we've taken forward, there's a lot of pushback, whether it's on finance or on the politics or on the machinery of getting to 2030 and the SDGs.
Shereen, thank you very much for that. Randevyn, how do you see things from your standpoint?
You know, we really understand that in order to end the epidemic, we really need to meet people where they are and where they want to be met and where they've never really been met before, with HIV education, with resources and services. And speaking as someone who's living in the Southern United States and who has been living there for 21 years, we don't talk about, and when I say we, I just mean in community, because I consider myself to be a part of community. And when you do hear conversations about HIV, it's not about, when will we end the epidemic? It's about, is there still a such thing as HIV? And what do you know about that thing they call PrEP? Or are people still dying of AIDS? And so my point is that there is a lot of lack of education, and there's a lot of work yet to be done. You know, we talk about the end of HIV, but we have a lot of work to do in educating people and empowering people. We got a lot of work to do on stigma. And so although ending HIV/AIDS is the destination, I think what's most important is that we remain consistent on the journey to really leave no person with HIV/AIDS behind, because there are tons of tasks and assignments yet that we have to get there.
Mm-hmm. Thank you, Randevyn. And if you consider that in 2004, at the high point, it looked as though there was no way we could get to where we are 20 years later, but transmissions are down 68%. And I would like the both of you to consider the various tools that have been employed, the political tools, the legal tools, the policy tools, the whole range of technological tools that have been used to try and get us where we are today, and consider, Shereen, how crucial health promotion and disease prevention have been, and how important they are going to be in this fight to end AIDS by 2030?
I think that's been one of the big shifts in how we look at HIV over the 40 years of the epidemic. And of course, in the early days, it was very much civil society that pushed forward in terms of access to medicines. More recently, and you point to it, Henry, it's not just individual behaviors that make a difference and are going to help us reach the 2030 goals, probably after 2030, but also bigger systemic structural issues. And one of the issues that I've been most closely working on are laws and policies. So I was the vice chair of the UN's Global Commission on HIV and the Law, and that published really a groundbreaking report about a decade ago on all the laws and policies, which most people don't think of. The law seems to be very arcane and remote, but actually has a huge impact on our ability to prevent HIV. And to give you just one example, if we look at sub-Saharan Africa, they found that in countries where there were laws criminalizing same-sex relations, and sadly the numbers of countries there are increasing, actually not just there around the world, but most notably Uganda, for instance, gay men and men who have sex with men have a 5 times higher prevalence of HIV than in countries where they don't criminalize such behaviors. And in these countries where, for example, civil society organizations come up against laws and policies that restrict their ability to work, there was a 9 times higher prevalence. So clearly working on the laws and policies at the local, national, and international level are absolutely key. And in the global AIDS strategy that I mentioned earlier, there are new targets, what we call the 10-10-10. These are on so-called societal enablers, so that by 2025, only 10% of people living with HIV and those at risk, our key populations, should be facing laws and policies which criminalize, and only 10% should be facing stigma and discrimination. I mean, this is clearly a tall order, but we have seen considerable success in shifting laws and policies, if not on paper, then in practice. And for me, coming from the Middle East and North Africa, this is really key, because trying to change laws and policies in places where we don't have really functioning democracies is tricky. And as Randevyn knows, even in places with democratic structures, laws can roll back, right? But it's changing the laws in practice. For example, how law enforcement officers will deal with women whom they find with condoms in their purses. So don't automatically assume that this woman is a sex worker and therefore must be arrested under the letter of the law. There are lots of ways that we can work with those pieces of the machinery to really promote prevention and treatment. But it's no easy fix, because that's a complicated confluence of politics and culture and religion and tradition and society and economics. So in your introduction, Henry, it was very interesting how you phrased it. You talked about technological advances, or should we let communities take this forward? Well, it's both, or we're never going to get to 2030 and beyond.
Randevyn, Shereen hinted at potential backsliding in countries which are deemed as advanced, especially when it comes to LGBTQ rights or AIDS prevention, promotion of health. Can you talk a little bit about that from your standpoint, working for ViiV Healthcare, an organization that is really trying to push at the technological frontier of pre-exposure prophylaxis and post-exposure prophylaxis and the medical and technological tools, but at the same time, you have difficulties with culture, difficulties with identity, difficulties with ideology, even in a country like the United States?
Yeah, I mean, I personally, I can say I've learned a lot. I spent my early life steeped in a fundamentalist religious tradition that was theologically unsafe for people of LGBTQ plus identity. And as a young church musician in the 90s, many of my mentors fell ill and many of them died. And it wasn't until I was an adult that I discovered that a condition called HIV was really the culprit. And that's really, what inspired my work in HIV. And so, I really think about stigma in HIV in particular is really a significant health challenge equal to any other. And I think we have to treat it accordingly. There are many things that we've missed along the way. And I think every time we miss something, the hope is that we're learning. And the community liaison team that I have the honor of leading really is built in listening, because we understand that that's really important as a part of the work that we do in the community to help advance our work in HIV prevention, because it can be a really significant challenge to learn from the patterns of what we've missed along the way so that we can continue our advancement in HIV prevention.
Shereen, it's one thing challenging stigma in a relatively open society like the United States or the UK or some of the Western European ones, but a different kettle of fish when it comes to the Middle East and North Africa region, which you're such an expert in. As a sexpert, how do you challenge stigma that is deeply rooted in tradition and faith?
Right. Just to be clear, I mean, the Middle East and North Africa, as we've heard from Randevyn, of course, it's not unique. Stigma and discrimination and all these incredibly repressive laws and policies. There's no Arab exceptionalism in that, sadly, growing phenomenon around the world. In Middle East and North Africa, our HIV infection curve is rapidly rising, and we've seen an over 60% increase in new infections over the past decade and a bit, which now puts us in the top position in terms of the league table of where HIV is rising, albeit from a very low base, because our epidemics in the Middle East and North Africa are still what we call concentrated. They're amongst the key populations.
This is really interesting, Shereen. How can it be slowing down in some of the poorest parts of Africa, Western, Central and Southern, and rising in a relatively more prosperous Middle East and North African region?
Very good question, and one which we deal with on a daily basis. Stigma and discrimination are a big part of it, clearly, and it's stigma and discrimination in the places where you wouldn't expect to find it, which is, for example, amongst healthcare providers, more educated members of the population. But again, it's to do with the taboos around the behaviors and practices which lead to HIV vulnerability in the first place. So same-sex relations, sex work, drug use. So if you have laws which are criminalizing the populations who are at greatest risk, it's not surprising that they're not being exposed to prevention tools. We have virtually no PrEP in the Middle East and North Africa. We have a couple of pilot projects here or there, but again, even condoms are not commonly used in sexual relations in the Middle East. And again, it's a confluence of factors. For example, we really don't have comprehensive sexuality education in our schools. I mean, they're trying to introduce it in certain countries, but it's a hard sell. If I can give you just one example of an entry point of how you can start to deal with all this, in the Middle East and North Africa, we have some of the lowest rates of prevention of mother-to-child transmission in the world. Only 23% of pregnant women in our region living with HIV are getting the medicines they need to prevent transmission to their children. Globally, that percentage is about 82%. So one of the ways you can deal with this is, for example, there is a global program which is called the triple elimination, that you eliminate the transmission of syphilis and HIV to your children. Pregnant mothers are given the treatment. We have one country in the Middle East and North Africa, Oman, which has been certified. It's got the Good Housekeeping Seal of Approval that has actually been able to roll out the programs thanks to community engagement and thanks to commitment by the government to prevent mother-to-child transmission. The importance of that, if you can roll that out across a conservative region, is that one, people aren't going to object to mothers and children being protected. It's less controversial than dealing with some of the other at-risk populations. But once you do that, you start to create a culture of prevention. And that's the tricky one, because we haven't really talked very much about why prevention is tough in the first place. You would have thought an ounce versus a pound of cure, that it would be an easier sell. But of course, it's really hard because one, you're trying to get people to stop doing things they quite like doing. And two, you're asking them to do it to prevent something. So the benefit is the absence, not the presence of a benefit. So trying to create these cultures of prevention, even in conservative settings where it's very hard to talk about sexuality, for instance, or indeed drug use openly, by these, so what I would call easy on-ramps, like mother-to-child transmission. It gets the machinery of prevention going. And that's how you start in conservative contexts.
Randevyn, just thinking about communities who are being left behind, whether it's in the United States, Europe, or the Middle East and North Africa, or elsewhere, how does one ensure that the benefits of all the work, technological work especially, that biopharma organizations, companies like ViiV Healthcare are doing, reaches those people. Because it's all very well having these great tools, but if they're not getting to the most at risk group, if it's not being properly targeted for ideological or other reasons, then they may as well not exist for those people.
That's a great question. For us, it's really important working with community and empowering community to explore their own solutions to HIV with our support. Making sure that there are culturally relevant initiatives, initiatives that speak to who the community is. A community needs to see images, for example, that look like them, language that they can identify with, that resonates with them. We have a program called Risk to Reasons that really addresses the language that we use to talk about HIV, because we know that words matter. So instead of using the word risk, we use the concept of reasons. What are your reasons for HIV prevention? And we pull together a group of Black women to advise us and to talk to us about what this initiative should look like. And it's called the Black Women's Working Group. And we allow the community and encourage the community to build this initiative, to build this work with us. And the job of those community liaisons are to connect to people who are doing the work. And the other part of their job is to go out to non-traditional organizations. So to go into Black churches, where I grew up and where I faced so much stigma and so much abuse and indoctrination in ways, and so much anti-LGBT thoughts and theology. So to go into those spaces with folks who are willing to have conversations about HIV prevention and about identity and other layers of this conversation that are really important to address, to go to civic organizations, to go to institutions of culture and art, and places where public health conversations maybe are happening and people are talking about health in very general ways, but they're too afraid or don't know how to address HIV. And our community liaisons give them the tools, share the tools with them, teach them how to, in some cases, talk about HIV in a way that can resonate with the community so that we can address stigma by using approaches that feel familiar to community. And I think just to touch a bit on the conservatism piece that is alive and well all over the world, really, to Shereen's point, it's really important to recognize the impact that being born and or raised and or influenced by that type of environment can have on the way a person sees the world, and not only the way that a person sees the world, but the way that a person sees themselves, and how that impact can influence the way that they see their treatment or whether or not they seek treatment. In some cases, whether or not they feel they deserve treatment, adherence, all of those things. I think part of that is I don't deserve prevention because my form of prevention should be that I just don't participate in this certain behavior, and seeing sexual orientation as a behavior and not as a way of being, and trying to stop what many folks describe and think of as natural urges. And so I think this conversation can go on and on and on. But there is a real need to educate folks and to give people different ways of thinking when they have been consumed, if you will, by conservative thoughts and theology and influence and customs and ways of being and thinking that sort of can drive them into these unhealthy spaces of not giving themselves or allowing themselves to have the care that they need.
Mm-hmm. Thank you, Randevyn. Let's get back to the HIV prevention technologies, Shereen. And in the early days of antiretrovirals, much of the talk was about equity and access, and how unfair it was that people in the epicenter, particularly in Southern Africa, were not getting the drugs that could keep them alive and allow them to live. I'm wondering, to what extent has the conversation changed? Because now we talk not only about antiretroviral drugs, there are so many other technologies now that deal with prevention. But I'm just wondering, are people who need it in the various regions of the world where this is still very prevalent getting it? Are governments asking for funding? Are they committing the funding? Where are we when it comes to this last mile?
Well, the last mile is a very long journey, isn't it? And clearly the HIV response globally is underfunded, and increasingly so in a world of crisis where there are many, many other calls on international finance. The UNAIDS calculates what they call the funding gaps, how much money is actually being spent in lowest and middle income countries, and how much money is really needed. And if you look globally, I think it's about $21 billion is being spent on HIV. And by 2025, to get us on the route to 2030, we need about 29 billion. And the funding gap is severe for prevention. And particularly for prevention to key populations. So you're talking about PrEP, for example. Yes, there has been terrific PrEP rollout in many parts of the world, but in many, many more, less than 5% of key populations are actually accessing the medicines. And that's in part because of the cost. But we're many, many years from that really rolling out widely. Vaginal ring, similarly. Again, it's a question, do people know about the availability of these technologies? And that's not just people living with HIV or those at risk, although Randevyn, I love the terminology you're using, reason versus risk. So those who are vulnerable to HIV, but even healthcare practitioners are not aware if you're not having the conversations about HIV in different circles. I'd just like to come back for a moment to Randevyn's point about community engagement, Henry, and because it's connected to this point about access to the tools of prevention. Prevention, for all the grand goals in the global strategy, which, for example, suggests that by 2025, 80% of prevention tools should be delivered by communities. We're a long way to go because of the financing, but also because of political ambivalence. On the one hand, our health systems can't cope. We know this is a problem. We need to get another group to help us. But on the other hand, we don't want to really empower communities that much because who knows where this empowerment will take them. And so it's a delicate balancing act.
Shereen, let's talk about vaccines. They have become huge in the public square, not least because of how quickly the COVID-19 vaccines were developed and rolled out. But what about an AIDS vaccine?
It's the holy grail of HIV, as it were, because we have seen over the years and in the last couple of years, great hopes dashed with clinical trial results, which have shown that really the technologies that we've been rolling out to date just are not working to prevent HIV in vaccine form. Now, the technology is moving along, and one could argue that all the experience that we've gathered from the HIV vaccine trials have helped to inform the COVID vaccine trials. And now that we have the new mRNA technology, that in turn can breathe new life into the HIV vaccine space. Of course, we have not vaccines per se, but Randevyn, perhaps you can speak to this, which is U equals U, undetectable equals untransmissible, so that people who are on effective treatment, in a sense, it is a de facto vaccine, if you like, because when their viral loads are undetectable, therefore they're not transmitting the virus. But even that, U equals U, is not well known in many parts of the world, and certainly not where I'm coming from in the Middle East and North Africa. So what U equal U is teaching us is that even when we have the tools, it's complicated to get the message out there. And that will also be the case when that happy day arrives and we have an HIV vaccine, because as we've seen, the pushback against vaccines in the context of COVID and all the false information and all that is really hard to remedy. And there's no vaccine for that.
Mm-hmm. Yeah, actually worked in that space at the time. And, what I saw was a lot of what has been called for years medical mistrust. It's a very real thing, and Black and brown communities in particular have a real reason for the hesitancy around some aspects of the healthcare system. It is actually a rational response to some of the atrocities that have happened historically, and we have a lot of work to do to rebuild some of that critical trust, because it really, if you think about it, puts the onus on the folks that were abused instead of putting the onus on the system that caused the abuse and the atrocities, right? And so to take a step back and reimagine the way that we frame this and the way that we're thinking about this, it's really about just building trust on both sides, from the side of the healthcare industry and also on the side of the person who's receiving care. And trust is built one experience at a time. And so this goes back to education, those conversations around, a vaccine or some other therapy that comes out that is pivotal in HIV, that folks are prepared and have the information they need to make the critical decision for themselves. One of the greatest tragedies is to be so removed and isolated and have such distrust of the healthcare system that you actually are not able to take advantage of the things that can help preserve your life.
Thank you, Randevyn. Let me talk about allies. You can have partners, you can have allies in a variety of organizations, some of which are in this space, the healthcare and the health promotion space. Others might see themselves as politicians, as industrialists, people working in the corporate environment. How do you reach allies and persuade them that this is part of a global fight for better healthcare for all, not just a fight for a stigmatized community?
So I think it depends where you are in the world. We've been talking a lot about the technological tools. We haven't talked so much about some of the good old-fashioned methods we have, like condoms, for instance, or voluntary male circumcision, or even more nuanced and complex issues. For example, being able to eliminate intimate partner violence can have a significant effect on women's vulnerability to HIV. The difficulty we have is in more conservative settings where, for example, it's hard, private sector in the Middle East and North Africa, it's not that easy to speak openly about HIV or to introduce, for example, non-stigma and discrimination programs at work when you are in a cultural environment which either A, doesn't want to talk about HIV, or if it does talk about it, tends to have very negative attitudes. So that is a harder sell, and that requires, I think, a repositioning of HIV. And one of the conversations, the sets of conversations we have around that in the Middle East and North Africa, is to say to governments in particular, you have relatively few cases of HIV at the moment. And when you're faced with war at your doorstep, economic meltdown, political crackdowns, whatever, you may not want to focus on HIV because you have a million other problems to address. But it's what I call the kaleidoscope effect. You turn the pieces and you look at HIV differently. And you say that you, government, working in combination with the other relevant actors in your space, don't look at HIV as a problem to ignore. Look at it as a possibility that because you have relatively few cases today, if you did employ the tools to prevent and treat, you could be one of the few countries in the world to reach that 2030 goal of ending HIV as a public health threat. So a lot of it has to do with creative thinking and creative engagement of otherwise resistant partners to make HIV look less of a liability and more of an opportunity for these countries to step up and do what others have really struggled to do.
Thank you, Shereen. And let's have a closing thought from you, Randevyn. I know you've written about human health and the condition of the mind and emotions and the state of our bodies, the fact that it's all holistic. And I'm just wondering how one presents that to a big organization that could be an ally, the Black Church in the States and the African Pentecostal churches on the continent of Africa, and persuade them that this is intimate, this is linked. The spiritual, the physical, the health, the body, the soul are all linked. You can't leave any behind. And they should be allies in this fight. They should be allies in the determination to prevent this disease and to try and eliminate it by 2030.
You know, one of the ways to destigmatize HIV is to align it with primary care and to present it as a part of our wellness and not to single it out. And I understand why HIV has been isolated for resources and those other reasons, but it's the same concept of aligning it with the other parts of us that needs to be healthy and that need to be whole. And so when we're talking about religious institutions, and in particular the Black church that has, not all Black churches, but many Black churches that have a very rigid sort of position around human sexuality and this one model that they feel all people should fit into, and any deviation from that is demonized, et cetera. And when talking about this with Christian leaders, I have aligned it to or compared it to the life of Christ, who spent much of his time making sure that people were well, making sure that people were whole, making sure that people were healed. And when having these conversations with the Black church, in particular, it is pointing to the responsibility of the church to make sure that people have what they need to prosper and have what they need to be well. People need love. People need comfort. People need health. And so the responsibility of those religious leaders, those people of faith, is to make sure that people have what they need in all of those ways so that they can meet their health equilibrium. Because HIV impacts every part of who we are. And once a person is able to seek that care, they can get back to other parts of their life. And I think in public health, as we move toward improved models of better understanding public health, it will sort of evolve to this idea that when we are well and when we are healthy, emotionally, physically, aligned, spiritually, for whatever that means for us, then we are whole, and we do get to a place where our health equilibrium is aligned with what it means to be fully healthy and fully well.
Randevyn Piérre and Shereen El Feki, thank you very much indeed. You've been listening to Can We End Epidemics, a series of 6 episodes where we discuss disease prevention, the future of medicines and funding, healthcare, among other issues. I'm Henry Bonsu, and until next time, thanks very much for listening.